Hello, everyone, and a warm welcome to today's edition of Pathcast. Today is Tuesday, November 21st, 2023. I am Rifat Mannan in California. Today, we are very delighted to have Dr. Romil Saxena with us, who needs no introduction to the pathology community, and she has been on our platform earlier. She is professor of pathology at Emory University School of Medicine. So we have a different format of Pathcast today. So let me give you the outline quickly for today's format. So the session is called Bring Your Own Cases. And as the name says, we will actually have 4 cases which will be shared by our colleagues who are joining us from different parts of the world. And all these cases are presented impromptu, and Dr. Saxena is not aware of the diagnosis. And they will share the case and they will discuss the cases, and Dr. Saxena will discuss with them and share her opinion about what she thinks. So each case will have 10 minutes of case discussion, followed by 5 minutes of Q&A session. And in that Q&A session, our audience on Facebook and YouTube, they will be able to actually post their questions on the chat box so that we can have a discussion based on whatever questions you put. So that would be much appreciated. And please note that patient's identity will not be disclosed in accordance with HIPAA policy. So with that, I would like to introduce our today's participants. So Dr. Saxena is there, of course. And then we have Dr. Hanna Lapsar, who is joining us from Ukraine. Then we have Dr. Irina Samarska, who is joining us from Amsterdam. Then we have Dr. Rimli Datta. She is joining from New Delhi in India. Then we have Yaroslav Dombrovsky, who is joining from Ukraine, Kiev. And we also have Dr. Vladislav Ilchenko, who is also joining us from Ukraine. So over to you, Dr. Saxena now, please.
Hi, everybody. Thank you, Rifat, and all the other participants for making this possible. And the idea for this session was that we all get to see cases from around the world, and also to see how liver pathology is practiced maybe in different parts of the world. And I hope to give you some insight into my thought process when I look at a liver, and it may not necessarily be the correct way of doing things, but it's just that this is what I do, and it may be right or wrong, I don't know. And I am sure that I'm going to learn a lot from the other participants, see their thought processes and how they practice liver pathology. So again, thank you very much, and I think we can start with the first case.
Hi everyone, I'm Irina Samarska from Maastricht, Netherlands. Dr. Saxena, thank you very much for your willingness to help us to share your expertise with us, and so we can learn from you. And my case is a female in the 5th decade. So far, the rest of some clinical data I will show after I show you the case. If you okay with that?
Yes, that's fine.
So I have H&E section of the liver biopsy. Can you see this on the screen? Yeah.
Yes.
So this is the liver biopsy. I will go very, very slowly along the core. And if you need me to stop or just to show some portal track, just let me know.
Yep. So far, I'm seeing, your portal tracks, the portal tracks expanded. There is an inflammatory infiltrate. I just go on low power initially, just zoom out.
Yeah.
And there is ductular reaction as well. So I think it's at this point in my mind, it's, a sort of a mixed pattern with both the ductular reaction as well as the inflammatory infiltrate. And I was looking at the bile ducts as you were going through, and it seems that they are present. So they're definitely not absent. And I'm trying to figure out at this point whether it is a primary biliary process or a primary hepatitic process. Of course, it could be both as well. But
yeah. So I will go a little bit faster because.
And there's no there's no real interface as I would expect in a chronic hepatitis, I would say. And you seem to have some delicate septa extending from these portal tracts. There's a bile duct there that's a little bit damaged. Granuloma, non-necrotizing. Yep, okay. So you have a bile duct that doesn't look happy at all, and there's another one there. So my instinct at this point, and it's only an instinct, right? Like what are the thoughts that through my mind is that it could be a PBC because we were starting off with a biliary process and I'm seeing granulomas destroying the bile ducts. So that's where I'm going with it. But of course, you have to think of the other differentials. So the other differentials for something like that in my mind are sarcoid and drug-induced liver injury due to whatever cause. And here I see, is that like a lymphocytic cholangitis next to the little, there's an arteriole and next to it is an inflamed structure. And I'm wondering if that is a damaged bile duct. Yeah, this one shows apoptosis and nuclear irregularity.
I was wondering about this. Is it not enough to call it interface activity?
So for me, it is not because with PBC, you do get interface hepatitis, which can even be of moderate intensity. So I don't jump to call it overlap or interface. So this type of thing you will always see in PBC. Almost always, I should say, not always, but almost always. So right now, I am still calling it, if this is indeed PBC, okay, if this is indeed PBC, I'm calling it PBC without any interface.
Yeah, thank you very much. Yeah, what the most trick in this case, I will show you the rest of the clinical data.
Yes.
And that so we have indeed some elevation of liver enzymes. There is ASAT and ILFP, gamma GT, but all antibodies were negative in serology, and also anti-mitochondrial antibodies were negative. And so the patient finally, I think it's like a differential diagnosis, but with favor of PBC. If
Can
you
you
agree
just
with
remind
that.
me of this? She's a woman of how old?
Yeah, in fifth decade. I don't remember exactly the
Okay,
age.
that's fine.
Yeah, fifth decade. Indeed, it was first presentation with the liver problems, and she's on the simvastatin medication. Could it be some drugs-induced liver reaction for simvastatin, for statins?
Okay, so simvastatin, it could be, but most cases of simvastatin just show elevated liver enzymes, and we do not exactly know what the liver histology might be. So in other words, we don't have the data, right? So it can never be ruled out, so it's possible. But my thought is that this is PBC because it's a corrected demographic. So it's EMA negative PBC or autoimmune cholangitis, what they call it. Do you have copper on this?
No, not yet.
Okay.
It's in a process. So I should. And what would you expect on the copper, the position of copper?
So I would expect some copper deposition in periportal hepatocytes. And if I see that, then I would be more in favor of PBC.
Mm-hmm. And can I use also CK7 as a surrogate marker of chronic cholestatic disease?
Yes, you can. But I think to me, the copper would help more. If you see biliary metaplasia of hepatocytes, I think it would be more in favor of PBC, because you are going to see ductular proliferation, right? You're going to see all that, or the ductular reaction. So that's not going to be that helpful, I feel. But I feel that the copper or the ORC would be very helpful. Any copper stain.
Okay. Thank you. I will do. I will order the case. Maybe someone has another question about this case.
Yeah, I see one question online. So the question is, let me read for you. What would be the incidence of AMA negative PBC? And a related question for Dr. Saxena, any other antibodies that could be tested? You can stop sharing, Irina, if you don't mind.
So you have that, what is it, the GP120 or something like that, that can also be tested. The F-actin is the other one, which is more sensitive, I think, but less specific for, it can be positive, in other words, in PBC, F-actin. And those are the two main things. So you can, those are the two main things that can be done.
Right. There is another question. Would you do shear staging on this biopsy?
It depends on what the clinicians ask you for, right? So there's nothing, at least the way we practice, what the clinicians are looking for is a degree of fibrosis. So we are not necessarily, I don't necessarily put a stage, but I do give a description of what the trichome shows. So I might say that it's portal expansion by fibrous tissue, or that there is periportal fibrosis or bridging or cirrhosis, whatever it is. I tend to be more descriptive in this rather than giving a Scheuer staging per se.
Right. Thank you. So there is another question for this case, Dr. Saxena. So what are the clues to differentiate PBC from autoimmune cholangitis? What should we pay attention to?
So it's the same process, it's the same disease, except that one of them is AMA positive and the other is not AMA positive. So if the AMA is negative, we call it autoimmune cholangitis. If the AMA is positive, we call it PBC. That's the only difference. So there's no differentiation on histology. I mean, we don't even attempt that.
Right. And there is one more question. So does the diagnosis of minimal change PBC still exist?
I mean, it has been shown in a paper by Dr. Neil Thies. So, and it's based on work that I had done with him, where we showed that the canals of Herring, which are the most proximal structures of the biliary tree, are attacked by the antibodies and are destroyed. So those are the first structures to be destroyed. And therefore, if you did a CK19 and you didn't see canals of Herring, then it could support a diagnosis of PBC. So in theory, I do believe it, but what I would caution is that CK19, in my opinion, and just from my experience, so this is not written in a paper, it has not been studied in a very case-controlled manner, but I feel that CK19 is a stain that can be a little bit tricky, and not every lab can do it very well. So you have to be able to do it in your own lab in normal cases and different types of liver diseases, and get a sense for yourself as to how many canals of Herring you can see around the portal tracts, identify them. And once you're comfortable with what the normal and what is increased, what is decreased, once you're comfortable with that, then you might be able to apply it. But to apply it in single cases, I would not recommend that. I think that optimize the antibody in your lab, see what the normal looks like, and only then should you rely on it.
Thank you, Dr. Saxena. I think these are the questions that I saw online for this case. So maybe we can move to case number 2. Over to you, Dr. Hannah.
Greetings, I'm Hanna Lapsar from Kyiv, Ukraine. These are the outlines for my case. This is the lesion-directed liver biopsy. Hope you see my screen.
Yes.
Our patient is female in her 6th decade. She has recently developed multifocal lesions in both liver lobes. She has known history of breast cancer, resected 2 years back, but I do not have an access to pathology report and details for that surgery. The lesion was one of the lesions was biopsied, was sampled because of clinical suspicion for metastatic breast cancer, and unfortunately I could not reach the doctor to get any lab results. So the histology for this case. We have multiple cores. They look pretty similar.
So what's happening there? What is all this? Okay.
It seems that there are some hemorrhages, but also there are multiple foci of prominent eosinophilic infiltrate.
Right.
Predominantly, like here they are, predominantly around the portal tracts. Oh, spoiler, no neoplastic process detected among all those scores. I would probably not show all of them.
Did she get any drugs? I mean, she must have been treated.
I think so, but I do not have the exact information. I believe she
would have
is
had something.
possible to receive some drugs.
So this is a tough one. And this is already making my making this a very successful session for me, because I'm seeing, you know, a very unusual case. There are lots of EOs. It seems to me that the architecture is preserved, right? So it's not a mass occupying lesion, in other words. And we have expanded portal tracts with the ductular reaction and the lots of EOs. You also have a lot of endotheliitis, actually. When you first showed it to me, I was wondering if it's an inflammatory hepatocellular adenoma, but now that you went a little bit higher, I don't think so. I think this is just the liver with all these lesions. So the question is, of course, a drug-induced cholangitis, right? Or hepatitis, something that's drug-induced and it's doing this thing. The other thing, when I see a lot of EOs, I would also think of Langerhans cell histiocytosis. And you have no history. You don't know anything about the imaging. You don't know
No.
about the treatment. So we are going purely on morphology. So with all those EOs, that thing in the portal tracts, just go a little bit higher. Yeah, so it could be something that's drug induced, of course. And with all the sinusoidal dilatation and congestion, that's another reason to think that. Langerhans cell histiocytosis. The other thing that shows you lots of EOs, of course, are parasites, right? Maybe, maybe not. And Hodgkin's disease. So I feel that if we can rule those two things out, if we can rule out Langerhans cell histiocytosis and Hodgkin's disease, then we are in the realm of a hepatitis or cholangitis, depending on what else you find.
Mm-hmm.
And then we come to what is the etiology, and with all the EOs, the highest thing on the list would be drug-induced. Now, what else? Am I forgetting anything else that can cause this type of hepatitis? I can't think of anything. The parasites are again on the list, but we need to know a little bit about the biliary tree. So if that is fine, I would move away from that diagnosis to something that's more, yeah. I don't think I can go any further than that.
Thank you. To be honest, I didn't think about Langerhans cell histiocytosis, either Hodgkin disease before. So I was thinking about drug-induced injury or parasitic infection.
Yeah, I think those are
the idea of hematological disorders didn't strike into my mind. Thank you.
So I'm seeing a question in the chat. And so for Langerhans cell histiocytosis, I would do a S100 and a CD1A. And for Hodgkin's, of course, you do a CD30 and a CD15, right? For drug-induced, there is absolutely no marker that you can do. We hope there was, but there isn't. And the other thing I would check, by the way, is there any blood eosinophilia? Okay. Because usually when you have tissue eosinophilia, you might have it in the blood, and in that case, it becomes an allergic reaction. It might be more due to drugs.
Thank you very much.
Thank you, Dr. Lapsar. There is one question online that I can see that what about eosinophilic granulomatosis with polyangiitis? That is what we used to call Churg-Strauss earlier.
Churg-Strauss is a good idea. Yeah, I didn't think of that. But Churg-Strauss is more of a vasculitis. And as I said, I haven't seen that. Now, Churg-Strauss is also, is it medium vessels? I think it's medium-sized vessels. And I'm not seeing a vasculitis, but that doesn't mean anything. I mean, I haven't seen the whole lesion, all the biopsies very well. It doesn't strike me as a vasculitis, but I could be wrong on that. But Churg-Strauss is definitely in the differential. This is more of an endotheliitis. And when I see endotheliitis, I'm thinking more of a drug, because that seems to be pretty common in drug-induced hepatitis.
There is another question, Dr. Saxena, that could it be paraneoplastic? Is it known in breast cancer?
Yeah, I mean, they are all possibilities. I don't know how you would prove that or not. The other thing that just hit me right now is there were a lot of plasma cells, right? IgG4, sclerosing cholangitis, I don't think it is. I don't think it is. But I just want to throw it out because there are a lot of plasma cells.
Yeah, there is another interesting question, Dr. Saxena, from one of our colleagues. Can drug-induced liver disease cause multiple masses that clinically was suspicious of metastasis? Because I think Hannah mentioned that there were multiple liver lesions for this patient.
Right. So it's entirely possible that they missed the mass, right? That there are true metastatic lesions that they did not sample. It's entirely possible, but so we can say that there's no malignancy, and then it's up to them to decide what to do. But right now, what I have in front of me is this liver biopsy, and we have to comment on this, and then say that there is no malignancy, and then if they really, they can go back and sample more. But the reason I also thought of Langerhans was because you were talking about masses, So because that could give masses as well. And what's this portal track? Can you just go back to where you were and just zoom in a little bit? What are these cells? Because there are no EOs, there are plasma cells here, right? Mostly. Yeah, I would also do the IgG4.
Thank you again. The idea I absolutely missed before.
Right. And one question is, what about autoimmune hepatitis as a differential?
It's possible. I have never seen so many
EOs, right?
EOs.
Mm.
And the interface is not that much. There are some portal tracks that are not involved. And then with the history and the morphology, autoimmune did not come first to mind. But of course, it is there in the differential.
Right. And another question is, can it be associated with hypereosinophilic syndrome?
Yeah, sure, it can be. But for that, you need to call it hypereosinophilic syndrome. You need hypereosinophilia in the blood. You need all the other clinical signs and symptoms of that syndrome, right? We cannot say that on a liver biopsy. But yes, can it be associated? I'm sure it can be associated. But look at all that endotheliitis there. That's pretty impressive.
And another interesting question, Dr. Saxena, is that is it just perilesional? Because there was some bile ductal reaction and sinusoidal dilatation and things like that we see on the biopsy.
Yes, it could be. So the approach to the liver biopsy, or well, not to the liver biopsy, to anything that we do in surgical pathology, right, is first, if you see something, then you would have to rule out things that are diagnosable, right? So we are seeing a lot of eosinophils, and which is very unusual, right? I don't see eosinophils like this ever. So if I'm seeing a lot of eosinophils, my mind first goes to what is it that can cause, well, I'm seeing two things. I'm seeing a lot of eosinophils and I'm seeing a lot of plasma cells. And so my mind first goes to what can do that, right? What can give you so many eosinophils? What can give you so many plasma cells? So, and I have to comment on that first, right? And I have to rule out anything that is diagnosable by me as a pathologist. So with eosinophils, Langerhans histiocytosis, Hodgkin's disease, and one more thing, by the way, is mast cells, mastocytosis. But that is not something that we're going to diagnose just on a liver biopsy, but you can do a stain for mast cells and rule it out, right? That's something that's within your power to do. And for that, you do a CD117 or a tryptase. A histochemical stain or an immunohistochemical stain. So those are the three things with EOs. Then the plasma cells are screaming at me. So then I'm thinking of IgG4. And of course, autoimmune is the other one. But again, I have seen so many autoimmune diseases. I have not seen, I've seen so many autoimmune hepatitis, but I've not seen eosinophils like that, right? So that's my morphology. These are the things that I can diagnose and rule out. The other option is to say you miss the lesion, and what we're seeing is something adjacent to the lesion, which is entirely true. But that does not take you away from the idea that you should rule out what you can rule out, right? That you shouldn't think outside. You should think outside. So that's what I'm trying to do here. And And then everything else falls into the realm of clinical-pathological correlation, right? Can it be hyper-eosinophilic syndrome? Sure, it can be, but first I must rule out what I can rule out, right? So that's how I'm approaching it, right or wrong. But that was how I was thinking in this particular case. It's a very unusual case. And what's sticking out are the EOs and the plasma cells to me. So with the clinical history, drug-induced is at the top. With the clinical history, drug-induced is absolutely at the top. But then we think of other things. And then the drug-induced could not only be in the liver biopsy, like somebody mentioned, it could be a hyper-eosinophilic syndrome related to the drug. But for that, you need your clinical symptoms and signs and your peripheral eosinophilia, I think.
Right.
So
No,
those are
actually,
my thoughts.
no, thank you, Dr. Saxena. There is one comment from another colleague of ours on similar lines, that there is a syndrome called DRAS syndrome, that is drug rash with eosinophilia and systemic symptoms. So yeah, I think that's a good thought that you have
Right,
mentioned already.
right.
Yeah.
So all those things are in the
Right.
differential.
Mm.
I've heard of DRESS syndrome. I have had biopsies where they said rule it out. I never saw a single eosinophil in those biopsies. So I have not seen a case literally. But I think you can say all that, right? You can say drug-induced, you can say DRESS, you can say hyper-eosinophilic. But the fact remains that as a pathologist, if you're seeing so many EOs and plasma cells, you should rule out what you can rule out, I feel. So.
Thank you. And one of our viewer is commenting that a pathologist is a cellular Sherlock Holmes. So that is you, Dr. Saxena, today.
Say that again?
A pathologist is a cellular Sherlock Holmes.
Yes, I
So
like that.
That means that is you today.
I like that.
So thank you, Dr. Lapsar, for this very exciting and interesting case. And
let us know the follow-up, please.
yeah, that would be great.
I hope I will get it, but I cannot make promises.
Okay.
All right, so we can move to the next case. Dr. Rimli Datta, please.
Hello everyone, I am Dr. Romil Datta. I'm joining from New Delhi. I work currently at AIIMS, and I'm really thankful to Dr. Saxena for sharing your expertise with us, taking out the time to do so. I'll share my screen now. Is it visible?
Yes.
Yeah. So I have two biopsies of the same patient. So this patient was is a young female in her early 20s. She had jaundice off and on from past, like when she was 5 years of age, with recurrent abdominal pain and episodes of epilepsy. She was a short stature patient and had grade 4 clubbing. On CCT scan, it was found that she had multifocal lesions in the liver. Her LSM score was raised, AFP levels were normal. Clinical impression was that of a young onset CLD with liver SOLs, with a doubt that could it be multifocal HCC. So they did a generous biopsy both from the lesion as well as from the adjacent liver. So the first biopsy fragments which I'm showing is from the liver lesion. So as you can see, there are multiple fragmented cores. So I'll take you to one of the core. Is this power fine, or do I need to go a little higher?
No, what's going on here?
This is from the liver lesion.
Yeah, okay. Just keep moving, yeah.
I can go to another core. All these cores were meant to be from the lesion.
So maybe go a little lower.
Okay. Sorry.
Can I ask you, is the patient cirrhotic?
Yeah.
Patient cirrhotic, okay. And okay, just show me another core at a low power on the other side. Yeah, keep going. And can you zoom in on this one that's coming up? What's that structure next to, what's the structure? Yeah, what's that?
Is it this?
Yeah, is it a border tract type or a septum? Yeah. Okay.
I thought it was the fibrotic septa, which was like cut
Yeah, okay.
transversely.
So zoom out again and zoom out further. Okay. So do you have a reticulin on this?
Yeah, but the retic is not that great. I'll show you.
Should go to, okay. Mhm. So I think these are regenerative nodules in a cirrhotic liver. What is the
Okay.
imaging?
Imaging said that multifocal lesions. So and
But
they were
what
suspect.
about like there was washout or anything like that?
I don't have those details. Only thing what they gave me was like they were suspecting can it be a multifocal HCC. I can show you the adjacent liver also.
Yeah.
I'll go a little. Is this far fine?
Yeah, just keep going. Can you go higher now? Can you go higher here? Okay. Zoom out again, zoom out. And zoom in here. Can you zoom in here? Okay. Do you have any other stains that you have done?
Yeah, I have, I guess, glutamine synthase.
Okay. This is the lesional? No, this is
The
the,
lesional. Yeah,
this is
this is the
lesional.
lesion.
Okay.
So it is little heterogeneous. What I could see was that somewhere it was staining like little more than the rest.
What else? What other stains do you have?
I have
Show me
one
the
second.
CD34.
Yeah. Sorry. One second. One second. This is CD34.
We are in the lesional or non-lesional?
Lesional.
Okay. Okay. Well, it doesn't help me really. Okay. So I think it's a cirrhotic liver with regenerative nodules. I cannot make it a hepatocellular carcinoma.
Okay. Would you think of an adenoma in this case?
Huh?
Would you think of a hepatocellular adenoma in this case? Or any dysplastic nodules?
What's that?
Dysplastic nodules?
Oh, I don't think so. Let's go back to the lesional. I didn't think it was dysplastic.
Okay. This is the lesional.
Mm-hmm. So why don't you show me the areas that you were worried about?
Yeah, sure. This areas only. I thought that there was some increased cell thickness. Somewhere there was some pseudo-Saxena transformation.
So there
And
is,
based,
it is thickened, but I think that this is where it's regenerating because you're near the fibrous septum. And I think that with the trichrome, I'm sure there's fibrosis here, right?
yeah,
Like thin
I
septa
can,
going around, I feel.
yeah. Trichrome showed fibrosis. Let me pull up the trichrome.
And this is lesional tissue, correct?
Yeah.
Yeah. So obviously this is not, this is
Not
nothing.
a,
Like this area is not what they were
okay.
seeing. But if you go to the other core that had a long, without any fibrous tissue.
This one?
No, the small one in the, like the, I think these are all regenerative nodules
Okay.
because it's so badly distorted, the parenchyma here, that what you're seeing are big nodules.
And just ignore the staining pattern of the glutamine, right?
Oh, yeah, absolutely.
Okay. All right. Thank you.
Thank you so much. Yeah, there are a couple of questions I see online. So one question is about what about multiple FNH or multiple FNH syndrome for that matter? That's a question.
Yeah, but I didn't see any features of FNH, right? I didn't see the abnormal blood vessels and the scarring because this and the background liver is really cirrhotic. It's advanced fibrosis and very badly distorted. But I didn't see any features of FNH. So
Right. And there is another question, Dr. Saxena. What ICs can support the diagnosis of a neoplastic hepatocyte from benign? So, and that is a very well differentiated HCC from a regenerative nodule if we don't see portal tracts.
unfortunately, there's nothing. I wish there was. We all wish there was something, but there is nothing. And sometime back, and of course, there's a paper that talks about glutamine synthetase glypican 3 and HSP 70, which will differentiate or, at least take you nearer a diagnosis of malignancy as opposed to something being benign. If you see 2 of 3 markers or 3 or 3 markers, that sort of thing. But there is no single marker that will tell you what is benign and what is malignant. And to me, the best stain is obviously a reticulin stain.
Right. And one comment from one of our online viewers, Dr. Saxena, that CD34 seems like it showed sinusoidal capillarization in this case in some areas. So what is your comment on that?
So my comment is that CD34 is basically, like you said, showing capillarization of the sinusoids, and capillarization of the sinusoids is, it is useful for diagnosing hepatocellular carcinoma if you see those thick plates, but you also see capillarization of sinusoids in cirrhotic livers, and I had stained a few cases of cirrhosis in the past with CD34, and the smaller the nodules, the more the capillarization, and the larger nodules will show it more at the periphery and not in the center. And it just depends upon the pressures, right, of the flow. And because there's so much vascular shunting in the cirrhotic liver, you do see capillarization without it meaning a whole lot.
Right. I think that's a great point. Thank you for bringing it up because otherwise CD34 can be misleading as this case is showing. And one last comment rather from one of our observers is that reticulin seems not very helpful for this patient. I mean, what we saw online, and was the retic thick or not? So, I mean, yeah.
It was not a very well done reticulin. So that's why I didn't spend any time on it. So the reticulin stain is is the most useful stain in liver pathology, in my opinion, but it is also an extremely difficult stain for the lab to do. And the tricky step is the what do you call it? It's flooded with excess silver, and then it is de-differentiated. So the silver is then taken away, right? And that de-differentiation step is an extremely tricky step. Not all labs can do it. So if it's not a well-done reticulin stain, I don't look at it because it means nothing. And in this one, I don't think they even got the silver on that thing, or they did it differentiated well. I don't know what happened there, but it was not a good stain. So to me, it was non-contributory in this particular case.
Right. No, I think, no, thank you, Dr. Saxena. This was very insightful. And thank you, Dr. Datta, for sharing this very challenging case again. We can move to our fourth case, and I would request Dr. Yaroslav Dombrowski, please.
Yeah, hi everyone. Name's Yaro. I'm a pathologist from Kyiv too. This is a Ukrainian fest. All right. So can you see my screen? Oh yeah. Okay. So everything that we know, it's this is a male patient in his 40s, and unfortunately, there is no information about primary lesion. And this is an allograft, yeah, and this is 10 months after transplantation. And there are some complaints from fever, and on MRI there are some multiple focal lesions, and well, clinical suspicious for acute cellular rejection. We have one core. Can you see it?
Yes.
Thank you. So it's a little bit strange for me that there are some well, focal lesions on MRI, but okay, that's all that we got. And on the center of this trithium biopsy, there are some kind of scarring, or maybe, well, there is no liver parenchyma. So I just won't tell nothing. Just wanted to hear, what do you think?
So I'm seeing sinusoidal dilatation. I'm not looking at the portal tracts right now. I'm looking at the sinusoidal dilatation, and I'm seeing perivenular fibrosis actually everywhere, right? The portal tracts do have some inflammation, but we won't focus on that right now because we are focusing on the lesion. And if you go back to that lesion, like here, it seems that there is loss of hepatocytes, and the sinusoids are remaining, I feel. And it's very paucicellular, so there isn't a whole lot of inflammation. Of course, the patient is immunosuppressed, so, that may take away some of the inflammation. But I'm wondering if this is actually an ischemic necrosis in this area. And the fact that there is perivenular fibrosis also makes me think that maybe there is some compromise of the hepatic artery or the arterial flow. So that's what I'm thinking. And of course, if there are fevers and we want to rule out an infection, we could do, fungal stains and AFP and that sort of thing. But it's so paucicellular, it's not very inflamed. And I am thinking that this is probably an area of ischemic necrosis.
Yeah, so it can give a picture of some focal lesions on MRI, and or maybe I was I was wondering about, okay, what is acute cell rejection? It's firstly it's affects it affects bile ducts, then arteries, and almost never veins of portal tracts, but sometimes central vein. And I think bile ducts are affected, and there are too much neutrophils for me. And I was also wondering about maybe ascending cholangitis or something like that.
So, so there are two things, right? First is the lesion, which may be ischemic necrosis. And then this is an allograft. So we are always looking for things like rejection or anything else that might happen. And there may be acute cellular rejection in the portal tracts. Okay. So two sort of different things. One is the ischemic necrosis, which may or may not be related to chronic rejection or arteriopathic rejection, and the cellular rejection. So these could be two different things. One is the acute rejection, and then the second thing is that there is ischemic necrosis because of whatever, or it might be an acute and chronic rejection. But the bile ducts are not lost. And if you had arteriopathic rejection, there would be loss of bile ducts and a lot of cholestasis, which I'm not seeing.
Yeah, I agree, but I'm not really sure about bile ducts, because for me, I can't, see clearly if we just go away from this lesion. So okay, we have, maybe this is a central vein, maybe this is a portal tract.
Yeah.
And we have some ductal reaction, and I can really see, a good bile duct, and probably it's affected, and there are not so much plasma cells. There is a lot of neutrophils. One of my differentials was, can it be, kind of ascending cholangitis, and after that there was some ischemic necrosis or some just scar, and ascending cholangitis can really provoke acute cellular rejection.
Yeah, so a lot of things, you're right. A lot of things can provoke acute cellular rejection. I'm not thinking acute cholangitis because I didn't see neutrophils within the bile duct lumen or within the epithelium. So that's why I wasn't thinking of
Yeah.
that.
Yeah, exactly.
So I'm thinking more of a rejection, actually, like a acute cellular T-cell mediated rejection in the 2016 BAMF criteria. That's what they call it, the T-cell mediated rejection. So that's what I was saying of the portal tracts. And because of the perivenular necrosis, fibrosis, I'm thinking that there is some ischemic damage going on as well. Or there have been previous episodes of rejection which are giving rise to the perivenular fibrosis. There are so many things that can happen in the allograft, right? So
Yeah.
so as far as the clinician is concerned, right, what are we going to tell them? Well, the first thing they want to know is a rejection or not? And I think that there is some rejection, cellular rejection that they can treat. The second thing is they want to know what is this lesion that's, space occupying lesions or the multifocal lesions. And they seem to be, in my opinion, it's ischemic necrosis, but it could be an infectious process. It doesn't seem like it, but, if we could throw some stains on it and see if anything pans out, or if there is something in the blood, but it doesn't look like an abscess. It doesn't look like, I don't know, a fungal infection, granulomatous inflammation. We're not seeing that. So I think that these lesions are probably ischemic. So as far as the clinician is concerned, their concern is what we are addressing. And those are the two things that come to my mind at this point.
And what do you think? How old is this, necrosis? There is no fibrotic changes,
Right.
not yet.
So it's not very acute because you
Mhm.
have these foamy macrophages that are sort of eating things up, I feel. And so it's not long, but it's not like very acute. So it could be a week,
And
2 weeks.
mhm. And can all this, neutrophilic inflammation could be explained by necrosis and post-necrotic changes,
Meaning
or
what
it's
we're seeing here,
sorry?
what you're showing me on the screen.
Ah, uh, could all these neutrophilic infiltrations be explained just by post-necrotic changes, post-ischemic necrotic changes, or is this because for me it's it can be acute cellular rejection. There is some focal ischemic change, ischemic focus, and but I also want to put in my differentials for clinicians also infectious disease, some kind of infection.
Right. Infectious disease based on the neutrophils around the bile ducts.
Yeah.
Right. So the bile ducts that you are seeing in the viable region, I have seen that with just rejection, right? And unless you
Oh,
see neutrophils within the bile duct lumina or the epithelium, I don't like to call it infection, right? So that
yeah,
part is out. Now the necrotic area is the one where you might be thinking of infection. And you're seeing
yeah.
the bile ductular proliferation with the neutrophils over there. I think that is a regenerative phenomenon that the liver, whenever it's damaged, it will give rise to bile ductular reaction. And the bile ductules, they secrete some interleukins, I think it's interleukin 6, that attracts neutrophils to the bile duct. So every time you see bile ductular proliferation, you will always see neutrophils around those bile ducts. And it's because those bile ducts are secreting interleukins. And as I said, I think it's interleukin 6 that does it. So that's just part and parcel of the process. It does not, in my mind, evoke an infection, if that helps.
Yeah. This is a great point because neutrophils in the lumen, it's a hallmark of infectious cholangitis. Okay, great. Thank you very much. Thank you. Okay, I think I've done.
Yeah, thank you. There are some questions online for Dr. Saxena. So one of our colleague was thinking that, oh, what about stains? Like, I mean, we have not talked about stains. So do you need any stain for this particular case?
Oh, like fungal stains and AFB is what we routinely do over here.
Mhm.
But we know that even if they're negative, it doesn't mean anything, right? You have to do some
Right.
microbiology, heavy duty microbiology. And of course, in the United States, we have MALDI-TOF that they do and get the organisms. So on histology, we are not always going to see it, but those would be the only stains.
Right. And there is another question that I saw about what about the beginning of vanishing bile duct syndrome due to ischemia?
I didn't see that. I saw the bile ducts. I saw lymphocytes within the bile ducts, which made me think of acute cellular rejection. If you're talking about VBDS or vanishing bile duct syndrome, we are not seeing senescence. You want to see those senescent changes in the bile ducts. I did not see that. So that's why I wasn't thinking of that.
Right. And another question for you,
If
Dr.
at all, this type of ischemic change can give rise to strictures and secondary sclerosing cholangitis. But I'm not seeing the vanishing bile duct or chronic ductopenic type of changes right now.
Right. And one more question that I saw is, what about hepatic outflow obstruction with is there perivenular fibrosis and things like that? Is ascending cholangitis in the differential? So there are questions like that in the chat box.
Right. So ascending cholangitis, once again, I want to see neutrophils within the bile duct epithelium, within the lumen, which we didn't see. So that's why I didn't want to call it that. And outflow obstruction, it's not making sense in the context of the whole thing, the whole thing. But if you just look at sinusoidal dilatation, sure, it can be due to obstruction. I would, yeah, because sinusoidal dilatation is such a common finding in liver biopsies, and especially in the allograft. So we can't keep saying that all the time, because some people I know will say it all the time, and then the clinician has to go and do imaging and this, that, and the other, and it's wasteful of resources, and it also takes you away from the real problem, So I tend to gloss over it unless it's really severe.
And is it outflow obstruction changes, are kind of earlier changes after transplantation?
Say again?
Because it's 10 months after transplantation.
Right.
Usually outflow changes, some changes that related to outflow impairment becomes earlier after transplantation.
So let me just put it this way. I have seen a lot of sinusoidal dilatation, right? But I've seen only 2 or 3 real cases of hepatic vein obstruction when they really found it and they did something about it. One, the hepatic vein was obstructed, and another one, the hepatic vein was kinked. So, and the third one was also obstructed. So I've seen 3 cases in 25, 30 years, but I've seen a whole lot of sinusoidal dilatation. So that puts it in new perspective. And then if you keep calling it every time, and then they have to go and do the imaging and do this, it's a big, it's sort of ineffective, let's say.
Okay, great. Thank you.
I think these are the questions that I saw overall. And we have come to the end of these sessions. So it is at the hour now. And maybe, if we have any case, we can discuss it at the next session. And I really want to thank Dr. Saxena for this very engaging session. And I also want to take this opportunity to thank our colleagues who joined. I want to thank Dr. Dombrowski, Dr. Samarska, Dr. Lapsar, and Dr. Datta, who joined from different parts of the world. And of course, Dr. Ilsenko also. Sorry, we could not have your case discussed today. So we will definitely discuss your case next time when we have our next session with Dr. Saxena. And it was really nice, Dr. Saxena, that you shared your experience, and our pathologists from across the world, they have shared their cases. And this was a really wonderful session, and hope we all got an opportunity to learn. And you would be happy to hear, Dr. Saxena, that we had a lot of viewers who joined from different parts of the world. I saw viewers joined from India, USA, Mexico, Sudan, Turkey, just to name a few places, Egypt as well. And thanks to all our viewers. I think this would be the last session for this year, and we will not have probably a session for December. And I think so I would request you all to follow Pathcast. So we have a website, we have a Facebook page, YouTube channel, and on X or Twitter, you can follow us also. And there is a what's it called, Instagram account as well. You can follow that. And thanks for your continued support. And thank you all. And thank you again, Dr. Saxena. This was great learning from you. Thanks so much.
Well, I saw some good cases, so I really appreciate that. I hope that what I said made some sense, and I know that I could have been off the track on many of these cases. So I appreciate feedback. You know, right or wrong, like if I'm wrong, tell me. If I seem to have said the right thing, let me know as well. And I'm especially interested in the eosinophilic case and the child with the multifocal lesions, particularly, and of course Yaro's case as well. I wanted to get follow up on all these cases if possible.
Yeah, thanks a lot. Thanks so
Thank
much.
you.
Thank you.
Have a good one, everyone.
You too. Bye. Thank you.
Thank you all. Bye.
Thank you. Thank you very much.
Right.